Thank you for attending this virtual COA hearing on proposed revisions to accreditation standards. My name is Laura Bonanno, and I am the current president of the Council on Accreditation.
Hi, I'm Frank Chabasi. I'm the Chief Executive Officer for the Council.
Frank and I appreciate the opportunity to provide you with this hearing on the proposed revisions to the accreditation standards. Before we get started, I would like to acknowledge everyone who currently serves as either an on-site reviewer or a consultant for the Council, because we could not complete our accreditation activities if it were not for these dedicated volunteers. And then last but certainly not least, I want to recognize the COA accreditation staff. These individuals put forth an exceptional effort for our organization every day, and they deserve special recognition. So I want to first start with providing you a little bit of background. At the January 2020 COA meeting, the COA reviewed the first 5 recommendations for proposed changes to its standards from the Standards Revision Subcommittee, which was established by the COA to review the full scope of practice competency task forces recommendations for potential changes in the accreditation standards and policies. In accordance with COA policies, a hearing on these 5 proposed revisions, as well as other revisions to ensure compliance with USDE recognition requirements, was held at the February 2020 ADCE meeting. A hearing was also scheduled during the AANA mid-year assembly. However, due to COVID restrictions, that hearing was not possible. In addition, a call for comments was distributed to the communities of interest and was open from May 15th through June 15th. Comments were submitted by nurse anesthesia students, faculty, practitioners, institutions, the public, and the higher education community. Information regarding the call for comments was published in the AANA's Anesthesia Essential and posted on the COA and AANA websites. The COA reviewed the comments from the hearing at the ADCE meeting and the call for comments at its June 2020 meeting. Also at the COA's June 2020 meeting, we reviewed an additional 7 proposed revisions to the standards that were recommended by the Standards Revision Subcommittee. A hearing on these proposed revisions, as well as the initial 5 proposed revisions, was held at the AANA Annual Congress, which was held virtually in August. As was done for the first 5 proposed revisions, a call for comments was distributed to the communities of interest and open from August 15th through September 16th. Comments were submitted by nurse anesthesia students, faculty, practitioners, institutions, the public, and the higher education community. And information regarding the call for comments was published in the AANA's Anesthesia Essential and posted on the COA and AANA websites. Today, we are presenting this hearing for the final proposed revisions. Due to fewer comments being submitted on the final portion of the proposed standards revisions, the COA is now conducting an additional call for comments in order to encourage broader participation in the standards revisions process. And we request that any member of the community of interest who did not participate in the September call for comments please provide their feedback. If you have previously provided comments on the proposed revisions, the COA appreciates your input and asks that you do not complete the survey again. To assist in reviewing the proposed revisions, please refer to the document titled Proposed Revisions to the COA Standards, which is located on the web page with a link to the video. Your comments are encouraged. So again, please go to the web page and access the link to the survey that's posted on the same page as the video. The first proposed revision is to add a glossary definition of full scope of practice to the master's and practice doctorate standards and accreditation policies and procedures. Currently, the standards and accreditation policies and procedures reference the AANA scope of practice, but there is not a definition of full scope of practice. So the proposed definition is preparation of graduates who could administer anesthesia and anesthesia-related care in 5 general categories. 1, pre-anesthetic pre-procedure. 2, intraoperative inter-procedure. 3, post-operative post-procedure. 4, pain management. And 5, other services. And these are 5 general categories. CRNA scope of practice is dynamic and evolving, and CRNA clinical privileges should reflect the full scope of CRNA practice evidenced by individual credentials and performance. So it's important to note that this proposed definition is more detailed than the one that was proposed by the full scope of practice competency task force, and this definition references the AANA scope of practice. In the initial call for comments, there were 56 responses, and 83% either strongly agreed or agreed with the addition of this glossary definition. There were 13 comments. The majority were supportive. However, there were a couple of comments that expressed the need to provide additional clarity and possibly some examples. In addition, there were several comments that expressed concern related to the inclusion of pain management and other services. The next proposed revision is to revise the radiology definition and establish a clinical experiences requirement to support the didactic content for chest X-ray interpretation. The proposed standard change would be to revise the glossary definition in the practice doctorate standards. So the highlighted portion in yellow is the revision that would be added. The definition would read, didactic curricular content includes the fundamentals of radiologic principles and various techniques, topographic anatomy, contrast agents, radiation safety, proper techniques of safe fluoroscopic equipment use, evaluation of normal and abnormal radiographs of the chest where findings may have peri-anesthetic considerations, evaluation of proper positioning of various devices, meaning endotracheal tubes, chest tubes, and invasive vascular access catheters such as central venous catheters, and experiences of chest X-ray interpretation are added. This proposed revision to the practice doctorate standards would be required for students matriculating on or after January 1st, 2022. So the proposed definition incorporates the recommendation to add clinical experiences to support the didactic content. Next proposed revision is to establish a minimum and preferred requirement for interpretation of chest X-rays to support the didactic content referenced on the previous slide. These requirements would be added to the appendix clinical experiences of the master's and doctoral standards, and it would be an establishment of a minimum and preferred requirement for interpretation of chest X-rays to support the didactic content. We would add in the guidelines for counting clinical experiences this following interpretation, that the expectation is that the student accurately interprets a chest X-ray, including recognizing normal and abnormal findings on chest X-rays that may have immediate peri-anesthetic implications, such as the ones we mentioned on the previous slide. This proposed definition incorporates the recommendations to add clinical experiences to support the didactic content because programs indicated that a formal radiology rotation was not an option. Simulation has effectively bridged the gap between the classroom and the clinical setting, and radiology operates on a mostly virtual platform, so clinicians oftentimes are reading images remotely. For this proposed revision, 45 out of 56, or 81% of respondents strongly agreed or agreed. The comments that were received included the need for clarification of the qualifications needed to teach this content, and there were a couple of respondents who disagreed with this change, specifically regarding the concern for the minimum requirements. We also added in this proposed standards change that one case should be counted as the interpretation of one chest X-ray, and students' interpretation is evaluated. The chest X-ray source can be a current or past patient or from an institutional or commercial library of chest X-rays. And this experience can be gained in a healthcare institution, classroom, simulation center, or by using online resources. So again, we have a footnote here that the experience can be gained in a healthcare institution, classroom, simulation center, or by using online resources. And this proposed revision would be required for students matriculating on or after January 1st, 2022. And again, in regard to evaluation of the student's interpretation, the evaluator should be an appropriately credentialed provider. The next proposed revision is to add 12-lead EKG or ECG interpretation to the curriculum. This proposed revision would be added in the practice doctoral standard, standard E2.2, where we talk about curricular content. You can see here what's currently in that standard And what's highlighted in yellow is where the 12-lead ECG interpretation would be added as part of the curricular requirements. And the key points here is that safe care can be contingent on the CRNA being able to interpret a 12-lead ECG to detect such conditions as myocardial ischemia and infarction in emergency situations, and when the patient is being monitored using properly placed ECG electrodes. For this proposed revision, there were 50 out of 56 responses in the initial call for comments, with 89% strongly agreeing or agreeing with this revision. There were 12 comments, and those that were positive focused on the fact that this content was important and currently taught in the curriculum. There were a couple of comments from those who disagreed, which primarily were focused on the thought that this skill is expected of critical care nurses upon entry into a program, or that there needs to be clarification of what is meant by peri-anesthesia implications. This is just a continuation of that proposed change, and here you can see the addition of a glossary definition, which would be added here for 12-lead EKG interpretation, and this is that didactic curricular content and the use of 12-lead ECG to detect cardiac abnormalities having peri-anesthesia implications. And this proposed revision to the practice doctorate standards would be required for students matriculating on or after January 1st, 2022. The next proposed revision is to add examples to the comprehensive history and physical assessment definition. You can see here the addition would be what is highlighted in yellow, and this would be to add the following examples, including but not limited to laboratory, radiologic, and other diagnostic studies, including chest X-ray or 12-lead ECG and point-of-care ultrasound as appropriate. So that would be added to the current definition. And the key points here is that expanding the definition of comprehensive history and physical assessment with specific examples emphasizes the importance of these skills and techniques to independent CRNA practice. And these proposed changes are aligned with the AANA scope of practice documents. In the initial call for comments, 48 out of 56, or 88% of respondents, strongly agreed or agreed with this revision. There were 14 comments, and the majority were supportive. There were a couple of comments from those who disagreed with this revision, who expressed the opinion that anesthesia providers do not do comprehensive physical assessments. And this is just a continuation of the current definition of comprehensive history and physical assessment, which is continued from the previous slide. Again, this proposed revision to the practice doctorate standards would be required for students matriculating on or after January 1st, 2022. Okay, now I'd like to turn this over to Dr. Jabasi, who will present the final proposed revisions.
Thank you, Laura. This proposed requirement, the next one, is to establish clinical experiences that specifically focus on a pre-anesthetic assessment, post-anesthetic assessment and management, and a comprehensive history and physical assessment. The minimum required case numbers are 50, and the preferred number of cases would be 100 for the initial pre-anesthetic assessment. The comments received, over 72% of the respondents agreed or strongly agreed with this proposed requirement. The specific components, the pre-anesthetic assessment, the post-anesthetic assessment and management, and the comprehensive H&P, were not separated in the previous call for comments. So to better identify the ratings and the comments, they have been separated in this call for comments. This requirement for these minimum case numbers would be effective for students matriculating on or after January 1st, 2022. The interpretation of this requirement would be identified in the guidelines for counting clinical cases as identified in this slide. It's important to note that there is this should be an original assessment, not a review of or reference to a pre-anesthetic assessment that's been previously done. The assessment should be evaluated by a faculty member, and that clinical experiences cannot be obtained by simulation alone for this requirement. It's an important part of the AANA scope of practice. A thorough pre-anesthetic assessment is fundamental for independent practice. And by adding this requirement, the council will be able to monitor and track the data as far as compliance with for making future adjustments to the requirement if necessary. The comments that have been received so far noted that students are already doing this and that clarification may be needed to define a faculty member to evaluate the pre-anesthetic assessment, and a concern regarding that it may be difficult to obtain this experience in some clinical settings. The post-anesthetic assessment requirement, as far as clinical case numbers go, would be 50 minimum required cases, and the preferred number is 150 cases. Again, interpretation of the post-anesthetic assessment would be provided in the guidelines for counting clinical experiences. As noted in the definition and interpretation that is identified here, this may occur anytime during the post-anesthetic period. This is not a post-anesthetic assessment that is required by the healthcare facility accreditors, and that documentation may be solely in the student case records, or it may be documented in the medical records if that is possible. The program must have a process for validating the post-anesthetic assessment if it's not documented in the patient's medical record. And that could be accomplished through the anesthetic care plan or in case logs. And clinical experiences cannot be obtained by simulation for this requirement. It's important to note that the post-anesthetic assessment is part of the AANA scope of practice. A post-anesthetic assessment is fundamental to independent practitioners' practice, and that by adding this component, the council will be able to track the data and then make future adjustments if necessary. As far as comments that have been received on this requirement, there was general agreement with it, but it was noted that it may be challenging as a large part of the patient population now is either ambulatory or 23-hour admissions. And clarification on how to validate the post-anesthetic evaluations and case logs may be needed, as well as concerns regarding the need to maybe decrease the number of required case numbers. As far as comprehensive history and physical, the proposed minimum required number of cases is 10, and the preferred number of cases is 20. And again, as in previous requirements, the interpretation for the comprehensive history and physical will be added to the guidelines for counting clinical experiences. The interpretation is identified here on this slide. The interpretation includes the scope of the assessment, what would be required as part of the assessment. A complete physical assessment should be included as a comprehensive history and physical, and it should be used to establish a differential diagnosis based on the assessment data and develop effective and appropriate plans of care accordingly. This experience can be obtained by simulation alone. It's important to note here for the comprehensive history and physical that this is not a pre-anesthesia assessment. This is a comprehensive history and physical that goes beyond a pre-anesthesia assessment. And it's important to note that this requirement is important in that it demonstrates the education that is required for entry into practice, which for CMS regulations for CRNAs has been instrumental in identifying recognition by CMS, so CRNAs are reimbursed for completing history and physicals. Simulation for the comprehensive history and physical should be an effective option. So programs can and should be able to use simulation to meet this requirement. The comments that have been received identified the importance that was noted and stated that there was some comments that felt that all H&Ps should not be simulated. There should be a requirement for some of these to be done in a clinical actual patient situation. Also, a question regarding the required minimum requirements of 10, in that may not be realistic, was noted. The last proposed requirement is that students have experiences in independently selecting, calculating the dosage, and administering medication. The proposed minimum case requirements for this to perform a general anesthetic with minimal or no assistance is 150. The preferred number is 300. Also, it was noted that the emergence from anesthesia, which is already a case requirement, was moved from the methods of anesthesia to the other category as identified here on this slide. Interpretation of this requirement is identified here and proposed to be added to the guidelines for counting clinical cases. The student would conduct a general anesthetic induction by selecting medications, calculating the dose, administering the medications, and then managing the patient's airway with minimal or no assistance from the supervising CRNA or anesthesiologist. The plan of care is always approved by the supervising CRNA and anesthesiologist. And as noted here in the key points, students may graduate never having done an induction without the supervising provider selecting and administering the medications. This was a concern that this may be occurring. And also the guidelines statement assures that the supervisor approves the plan of care. This requirement directly relates to a standard E9 in the practice doctoral standards that states that the curriculum provides students with experiences in the perioperative process that are unrestricted and promote their professional development as competent nurse anesthetists. 67% of the respondents agreed or strongly agreed with this requirement. And some of the comments supported the need for students to have some degree of independence and autonomy, clarification on how this will be verified, and concerns that the minimum requirement number may be too high were identified. That concludes the proposed revisions to the standards. Now I will return to Laura for our conclusion. Thank you.
Thank you, Frank. In summary, the COA directors appreciate the opportunity to present the proposed revisions to the COA standards. The COA welcomes your feedback. To submit comments, please visit the COA's website for directions on completing an online survey. The COA's website address is coacrna.org. So once again, your comments are encouraged, and you can submit the comments on the webpage. Pictured here, you see the COA council directors and Dr. Jabasi. I want to thank all of the council members for the incredible amount of time and effort that they contribute to the COA. This group of people are volunteers, and once again, we could not do what we do without their continued support. So a special thank you to all of them. So Frank and I want to thank you for your time and attention to these proposed revisions, and once again, we welcome your feedback.